Good to meet you. I guess so. They call me, right? How you doing? Josiah.
I'm not. I'm Cameron Bass.
Okay, Vijay.
Nice to meet you.
Are you the instructor
Yeah.
at the station? Okay, so I'm one of the mentee instructors.
Oh, right.
And I thought it said Rahal.
They changed the schedule earlier this week. I don't know if you were looking at the news. Maybe I'm wrong.
Let's do.
Pretty up to 5.
They're fantastic.
That's me.
Hi, we're here for next
Amazing. Amazing. I'm Cameron, I'll be your instructor. Were you guys in the group?
3. We got one more. I saw them around. Oh, no, I didn't see them.
All right, so just so you know what you're getting yourself into, a lot of time spent right around here. Might at one point ask you to roll over onto your left side. I'll talk you through that if it happens. All right, cool.
This is just a reminder that there is no food or drinks allowed in this room. Also, if you are for the life support and sepsis, please come to the front row.
Thank you kindly. Hey, how's it going?
I'm just going to take it for a second to bring something over.
Thanks.
All right, so what are we doing here?
So we're gonna talk about cardiac apnea.
With some of our views that we've already practiced.
You got it. It's gonna be taking the apical 4, apical 5. I know. But the good news
But
is,
we had a very difficult model the first time.
and we have a very fit person
That's
now,
right.
and more importantly, it's all about reps. We're gonna
Right.
get you there.
Okay, okay.
Tell me, we lost your.
We did. I
Tell me-
am
yeah.
a critical care nurse practitioner for about
Great.
15 years, but
Great.
I
Level
only
of
use it
echo
for lines.
experience?
I use it for lines.
Procedure
I don't
center?
do echoes that much. I watch a lot of echo.
Great.
And I look for, we'll look for lung sliding, stuff like that.
Awesome.
We don't use it enough in codes. We don't use it enough. So
Thus, you being here at this course, you're
Great,
gonna have the
exactly.
option. I'll offer that when I'm in a code situation, I exclusively use the
it.
subcostal window,
Right.
Because they can keep
Quick.
doing CPR.
Right. And we have a lot of doctors at the community hospital on steroids down in Melbourne, Florida.
Yeah.
Cape, Melbourne, yeah. So they have all the resources, but not any academia behind them.
Got it. Well,
great.
and now there's you.
That's right. Making me care.
I have to do some more, but this is get it
From
done.
University of Maryland.
Amazing. Oh, so you guys had the shotgun. Yeah.
So I just want to show you real quick
Yeah,
when
yeah.
you go into Doppler freeze, and
Uh-huh.
then when you go to measurement, if you want,
So we're not in Doppler yet.
we're not in Doppler yet.
Yeah.
You are correct.
Yeah.
Okay, measure,
See, this is what I need to
and you can just pick up this group.
Perfect. There we go.
and That's
And then if I want to real quick empty the save value so we can do it all again, is there an end exam button that I'm not
Yes.
seeing? There it is. Perfect.
Yep.
Got it. Thanks. Okay.
Here's our third person. We're all here.
Perfect. Great. I got to hear from Michelle.
Melissa.
Melissa?
ICU nurse person.
Very nice to meet you. Level of echo experience that you're coming in with?
Beginner.
Great.
Yeah.
Yogesh Paria.
Yogesh?
Yes.
Nice to meet you.
Nice to meet you.
So I'm Cameron Basson. I'm a pulmonary critical care doc out at Penn. I also run our POCUS program. So this is my jam. I use this all the time. Just conceptual. What we're going to do is we're going to take the view of the heart that was typically more challenging, which is that apical 4-chamber view. Remember, thinking about the heart sitting like this, you're going to be starting somewhere around the inframammary crease. And we're going to just fan slightly anterior. See what I'm doing with my hand? Just slightly anterior. And what that does is that opens up the aortic valve right in the middle. Once you have that aortic valve, we're going to be able to measure the blood flow through the aorta. And you can stop there, just to talk out loud. You can define someone then as being a high cardiac output state or a low cardiac output state, because you can make the assumption in most ICUs that their aortic valve diameter is stable. If you go into your book, I can see you've got it open to the page.
Yeah.
You actually have all the steps here. In the parasternal long axis view, if we're doing this to really figure out the cylinder of blood, we measure that diameter. It tells us to zoom in when we do it because this is an area of great inaccuracy, and because that value is squared, any mistakes we make are we got it. Then we get that apical 5-chamber view, and we're going to measure how fast blood is moving through that area.
First, we need to do the parasternal to get that.
It turns out that these machines let you do it in whatever order because they're going to save things for you. That's true of most machines. Thank you so much. That's great. But let's do it in the order that we're actually going to do it. I'll tell you again. If you're evaluating a patient over and over again, which is where I feel this test is most valuable, seeing how things change over time. Or with an intervention, I started epi, I gave them TPA, whatever it might be. Their aortic valve diameter has not changed. So you don't need to remeasure it every time. That's just adding more measurements. All right, Melissa, you're closest to the patient. He's just going to lean over. This cord's just going to drape over you. All right, I got some gel for you. Let's start getting a parasternal long axis view. Does that sound good?
Yep.
And as a reminder, you have to warn the patient that the cold gel is coming, or else evil spirits get them, right? And you're going for this angle, okay?
Okay.
And I'll help you by pushing some of the buttons. But Michelle, actually, do you want to come over here? We'll have
Yes,
she'll scan. You'll push buttons.
Oh,
What's
no.
So you didn't warn me.
I'm sorry.
There's no way to
He's
warm
caught
it.
you. He's caught you. All right, let's pause right here. Let's
Okay.
look down at your hand. The only thing that you're doing wrong is you're floating. So I want you to anchor the blade of your hand against the skin.
Pinky or something.
Yeah, there you go. Perfect. Just like that. And then, what are we seeing right here?
A-lines.
Lung. That's right. Lungs.
Yeah.
And so almost always it's lower than you think. So just slide. Oh, look, we're seeing cardiophasic
bit.
activity. And go and move a little slower. Yep. So just slide slowly towards his feet. Perfect. Pause right there. Ooh, you moved a little fast. Let's go slower again, slower again. This is a little bit lower, a little bit towards his feet.
I need to drop it one rib space. Oh, that's a little bit better, right?
Yeah, good. My favorite echosonologist likes to call that window shopping. Don't be satisfied with the first window you find.
Yes.
Okay? You're gonna pause
right.
here, right? Let's decrease our. Actually, let's do this.
It's got too much down here, right?
You got it. We got to
Okay.
decrease our depth. Okay. So
Every machine. is
every machine's
different.
different, and it's almost like we're trying to make
Depth.
this harder for you. You got it. So turn that knob. Nicely
bit
done.
more.
Keep going, keep going, keep going. Remember, you just want to
I
have the
wanna see the
descending
aorta.
aorta on the bottom of the screen. Perfect.
Okay.
And then, what we're going to do is we're going to zoom in because we said we want to be really precise with this measurement. Does everybody see the aortic valve leaflets
Yep.
right there? You're doing a great job, Melissa, holding that nice and still.
I know.
So you're going to hit the zoom button. Tap it.
Oh, tapping it can work? Okay, more?
Yeah. Zoom in more. There you go. And now you're going to bring that using this ball over to where we want to zoom, and then tap it again. See, now we're just in on that
yeah.
zone.
Okay,
Right?
and I'm measuring at the...
You're going to freeze.
Insertion.
So go ahead and freeze it. All right, Melissa, you can relax your hands.
I know.
All right, you're doing great. So now you can go. The nice thing about these machines is when you freeze it, you can go back in time. So if you didn't freeze it right at the point where you wanted it, you can go back
And we
until
want
you
it
get
mid? Is that what we heard?
Mid-systole.
Yeah,
Mid-systole?
mid-systole, right? So you can see the leaflets. So normally this green line is your tele leads. And you can, this green line right
Okay,
here, and you can see where your QRS complexes are, and you can assess
Right.
mid-systole there. But I'll be honest, my machines don't connect to the tele leads.
Uh-huh.
So I just go like this, and I look for, well, that's when the valve leaflets are completely closed. That must be diastole.
Yeah.
Now they're completely open.
Yeah.
That must be systole.
All right.
Right.
So now I got to find
Now you got to
halfway
measure
between.
it. You got to. Well,
Or you want 'em open. You want 'em
You want
open.
them open. You go, and you can go from like the moment they open to the moment that they close, and you can go. You can literally just roll the ball halfway.
Okay.
Cool. All right. So now let's measure it. So go ahead. And there's a button that says measure right there.
So measure them when they're fully open.
Yeah, because
Okay.
that's mid system.
And I want to
That's
make a line
mid-systole.
or...
Yeah, you're gonna make a line. So
M.
use the rolly ball,
Okay.
and you're gonna go at the hinge point of those leaflets. See that
This
right
one
there?
here?
Yeah.
Hinge.
Okay.
And you're gonna
Press.
click the left mouse button. Yep. And then scroll all the way down to the bottom.
How do I get that? How do I know? Like just straight?
Yeah, right there. I mean, you want to go hinge point to hinge point, basically. So it's probably, yeah, there you go.
All
Right? And then you hit the middle button to save it. And if you're like, wow, how am I possibly going to remember all the which buttons and which? Don't worry about it. Whichever machine you have in your institution, you learn how to use that. Is that right?
All
So
right.
now it says that distance you measured was 2.1 centimeters. Normal is between 2 and 2.5. He's right in that range. But we did something that's going to slow us down later.
Okay.
And the thing we did that's going to slow us down later is we didn't tell
Tell
the
it what I'm
machine what
doing.
you were measuring.
Okay.
So let's do that. Go ahead and click LVOT diameter.
Mm-hmm.
Now let's do that measurement.
Again?
No, it's sorry. It's got it. It's saved, all right?
Okay, it's saved.
Look
All
at the
right.
middle button,
Uh-huh.
and we'll unfreeze. So now the machine knows that that's the LVOT diameter.
Okay. Mm-hmm.
Now we need to tell it how much blood is going through that LVOT as we go. So now we go to our apical four-chamber view. Here's more gel.
I'm glad Melissa's doing it. I had the hardest
As
time
we go,
with it.
please feel free to ask
No,
questions.
we're gonna, yeah.
So we talked about just kind of sliding.
Yeah, we talked to somebody about
Ballpark.
finding.
Can you give us more depth? You can unzoom us.
Yes.
Hit the zoom button.
Zoom button. Out.
Yeah, good.
And depth-wise,
Pause right here.
we're good.
We're
Kind
gonna
of.
need a little bit more depth actually.
Okay.
Give it a
Where was the depth again?
here. What am I doing? Oh, look at you! Incredible. Got it. All right. You had cardiophasic motion a second
There.
ago. So pause right here. Whenever we have cardiophasic motion, we pause and we say, "I'm close." Now we do subtle motions, right? So I'm just cranking the gain to make it a little more obvious.
Mm-hmm.
So it's also really important to have one hand behind your back. That's how you know you're getting. I'm kidding. That's.
Oh, I was like,
Sorry.
Okay, this is the first time I heard that. Okay.
So when I look at where you are, right?
Yeah.
I see, wow, you're pretty high up. You're at like the nipple line. So I want to try one or six down and pause right here. You see how the heart's all the way over on this side of the
Yeah.
probe? Right?
I need to go this way.
And now go inferior. Good. Pause right here. Right? You see how I can see the ventricle, but I can't see either valve?
Mm-hmm.
That's a fanning problem. His heart's up like this. Right? Slide down as you do that. Good. And then you see how the apex is pointing towards your dot? Right? That means you gotta go towards your dot. Slide towards your dot. Oop, I was wrong. Slide away from your dot. There we go. And now you see how the septum's kind of like
Yeah.
this?
Yeah.
Right. How did we?
So that not rotation, but rocking. Yeah, the other way. Look at that. Now it's getting
Yeah.
closer to straight up and down. All right. There you go. Now you've got leaflet. This thing in the middle wants to be the aortic valve. So go ahead and slide just a little bit towards your dot. A little bit towards you. Yeah, there you go. Perfect. Pause right there. Let's give you just a little bit less depth. All right, now start to flatten out against the skin. Slowly, slowly. Yeah, there you go. Does everybody, just to identify the anatomy here, LV, RV, LA, RA. Does everybody see that?
Yeah.
And then right in the center here, as you flatten out just a little bit, you can give yourself more gel because you're starting to lose contact. Here, I'm going to really cover you.
Okay.
Here, you can pick your hand up. You're going to find it again. I like to tell people the gel's good for their skin. I don't know if that's true or not, but I like to tell people, okay? So go ahead and flatten. There you go. You see it starting to wide out? There's our aortic valve. And if you're like, man, Cameron, I still can't see that. That's okay. We're gonna practice it. And look down at your hand. Look down at your hand. You just migrated
Oh
4
my God,
centimeters
yeah,
that way
sure did.
because you weren't
Uh-huh.
anchored against the skin.
Well, that's a great.
It's a parasternal that you're
Yeah,
at right now because again,
exactly.
you're like way up there. You really want to be up high, even though we really want to get you down here. All right.
Getting there.
So do you see how like what I did there is I jumped to the inframammary crease and I started there as my anchoring anatomy externally, and then I'm closer. So now slide off of that rib. Oop, too much. Good. Pause here. Very slowly. Fan. Good. Keep going. Keep going. And very slowly, rock. The other way.
Let's try it.
And now fan. Yes, yes, yes. There we go. A little bit more. Can you get a little more fan? Good. Does everybody see the aortic valve?
Yeah.
Fan just a little more. Flatten out just. Yeah, good. That's the aortic valve leaflet right there. Does that make sense?
Yeah.
So mitral valve goes in this way, aortic valve goes in that way. I got one yes. You
Yes,
see it?
yeah.
Yeah. Great. So now we need to measure the blood flow through that. Hold your hand nice and still, Melissa. So go ahead and hit pulse wave. But first, sorry. This machine,
I want to go through that.
yeah, this machine, this orange dots, these are the pulse wave Dopplers. So you want to get that right at that place where you measured it. This is
Yep.
the same valve that you
Yeah.
measured a second ago. So just before the hinge point, you want that dot to be the hinge point. Tap PW. All right. And we need to change our scale, which I believe on this one is. That's our gain. Sorry, 1 second.
No, that's okay. I'm looking around too.
There it is, scale.
Okay.
All right.
Okay. Yeah, that's okay.
It's
Broke
all
off the
good.
chest for a second.
Let's find it again. Not a problem. All right, let's get there. Flatten out just a little more till you see. Yes. Now bring that dot right up to the hinge point.
Where am I?
You see that one
Yes,
heavy dot?
Yes. Where am I going? This way?
Flatten out just a little more, Melissa. Right here. And go here. I'm gonna help you
Yep.
out. Right. We're trying to
I'm
get
not
right
seeing
there. Right. So these are the valve leaflets. Great. Let's pause here. Let's do it. So go ahead and hit the pulse wave button.
I didn't perceive that like as easily.
I'm gonna help you.
Yeah,
I'm gonna
that's
help
okay.
Hit the freeze button. Melissa, relax your hand. All right. All right. You doing okay? Perfect. So now, does everybody see
Yes.
this directional deviation? This is blood flow through the valve. Down is away from the probe. Down is through that valve. Does that make sense? Now we need to measure this. Just as a note, if somebody has massive aortic regurgitation, you'll see that the down is countered by an equally big up. In this case, see how our gate is kind of like right up against that septum, we're moving around a little bit. This is not a great
Okay.
capture, but that's okay because this is your first time doing it.
Right.
Literally. So let's just practice conceptually what happens
We
next.
want it to be away from the septum if we can.
We
or
just don't want it. We just don't want it to hit the septum.
interfering.
You
Okay.
got it. But this is enough for us to get a measurement of cardiac output on that beat.
Okay.
And so the way we're going to do that is we're going to click measure. Perfect. And now over here we've got this cardiac output button. And what that does is it tells us the three things we need to measure for cardiac output. The first one we already did.
We
That was
did.
the diameter.
Right. We
Right?
did that already. It has a check
It
next
has a
to
check.
it.
Next is the LVOT VTI. Hit
All
that.
right.
And now we get to trace this. Okay? So use the mouse ball, go up to the beginning, and go all the way up to the orange line. The orange line.
The orange line.
Yeah.
Okay. Clicking over here.
Click there,
Okay.
and then draw your way down and then back up.
How far?
Oh, don't include the beard as usually the teaching. Yeah, there you go.
Maybe to here.
Yeah, perfect.
Okay.
Oh, no, and then back up.
And then back up. Do I have to click to make?
Did you click?
I did
already?
not.
Oh, yeah, no, don't click.
Okay.
Just keep rolling the ball.
Oh.
Yeah, keep going.
All the way back up to.
There you go,
the
perfect.
line.
Yes.
Okay. Well, but.
Perfect's a bit strong, but I'm with you.
Yeah.
You've measured that their VTI is 12.4.
12.4. I don't remember the numbers.
That's okay. We're going
All
to tell you
right.
that that's really low. That's super abnormal. He might be in cardiogenic shock. He's not. The reason we know he's not is because the direction of error. If I'm off axis when I'm measuring my VTI because my hand slipped or I didn't get right through the valve, it's a unidirectional error measurement. I can't measure falsely high cardiac outputs, only falsely low. Does that make sense? So if I come up and I get if this was 22, I would be like, I would not doubt that he's in a high cardiac output state. If it's 12 and it's this shape, instead of the one that's in your book of like this nice dagger, then I doubt that I was appropriately aligned and I really look closely. Does that make sense? All right, so now push the middle button to save that. Check. And the last one is the heart rate. And so if you had the tele leads, that makes it really easy. But we have an advantage here, which is we see the heartbeats. So go ahead and hit heart rate. And then you're going to take that, let's see, ideally we go, well here, so click once here.
On this guy.
Yep.
Okay.
And then we're going to go to the next heartbeat.
Which we can kind of see. Actually,
Do
no.
you want to go all the way over to this
one?
one? Yeah, let's do this.
Because I want to be in the same spot, which would be right
All the way
there.
there.
There?
Perfect.
right.
I don't think he's actually going 54. This is fine. All right? Ready? Click it. Oh, the middle button, sorry.
Oh, sorry.
It's okay. We'll just do...
Undo.
Yeah, undo is tricky on this one. There we go.
Okay.
Click
Start
that.
clicking this one here.
And then go to that
over
all
to
the
my
way.
one here.
Yep.
And the middle
button.
Got it.
And then at the bottom of the screen is a cardiac output measurement
Hi.
of 2.4 liters per minute. Just as a reminder, that's super low.
That should be his index.
We should be concerned. All right. But those are the steps, and now we'll, as the next person goes through, we'll
We're
talk
gonna do
about
it better.
Well, not just that. I'm going to talk about where the errors make this vulnerable.
Okay.
All right. We already talked about one of the spots, which is measuring that LVOT diameter. That's a vulnerability, right? Because it's
Big.
exponential, right? The second place is if my angle is off, and the third place is if I put my gate in the wrong spot. Cool. So we'll go through those in detail. Sound good? I'm going to tag out. Melissa, do you want to come do buttons? You guys, do you want to scan, and then I will have you.
Yeah.
Does that sound good? All right. So
Are we
let's
starting
just.
from the beginning or no?
I don't think we
No?
need. You tell me. Do you guys want to all practice measuring the OTV
Oh no,
diameter?
let's start with the VTI. I
Great.
think
Yeah. And so let's see if we can get a good VTI view. So go ahead and hit the 2D button to bring him back to scanning. It's this big one right there.
Got it.
Great. And that's all you need for right now. We're gonna
Okay.
let him scan. You see how over here there's a flickering thing? There you go. Slide towards it. Keep coming. Go just a little bit caudal. A little bit caudal.
Four
There you go.
chamber, right? And then we're gonna look for the
That's right. You start with your four chamber
yeah,
with
yeah.
beautiful
Yeah, yeah,
four
yeah.
chamber view almost. Just a little rotation to open this up. Yep. And then to go from that to the 5 chamber is that hand motion. Yep. There it is. Beautifully done. All right. So now bring that big dot to just proximal. I would go up. I would go for right here.
I feel like this is where I have no idea. What further?
Yeah, a little further. Yeah. And now can you help us out, Yogesh, just a little bit? Yet a better. Yeah, there it is. Now you can see those leaflets of the aortic valve a little bit better.
Yeah.
All right, good. Go ahead and hit the pulse wave button. PW. Let's get a few beats. Hit the freeze button. Amazing. Yogesh, you get to relax your hand. All right? Now, we're going to trace and then measure his heart rate. And as a reminder, this, just like everything else, saves it. You can go back in time and get a few more beats if you're like, I didn't like that. All right? So go ahead and let's hit the measure button. All right? You can cheat and use the cardiac output calculations button. That gets rid of everything except the measurements you need to do. Click LVOT VTI. All right? And then trace one of these big heart beats. Left mouse button, this guy. And then when you finish tracing, nice, beautifully done. When you finish tracing, hit the middle mouse button. Great. Because we still had the that diameter saved, and because it still has that heart rate of 50 saved, it's giving us a cardiac output. All right. Let's remeasure the heart rate by hitting that. Okay. Let's go ahead and pick the beginning to beginning. Left click and then middle click when you get to the next one. Hold on, wait, pause. That if you go just there, that's saying that this is the start of the first heartbeat and the start of the second heartbeat. But this is the start of the second heartbeat. So keep going. There you go.
Oh, okay. Yes.
Great. And then hit the middle button. Amazing. We got very similar measures to what we
very,
got.
yeah.
All right. And it could be that he's so relaxed that he's in a low cardiac output state, which is fine. It's probably just inaccuracies here, and we'll talk about how to get there. Do the steps of this make sense? As a note, this machine, incredibly powerful, incredibly complex user interface, right? Any of the machines here can do this, and many of them, because they have fewer other options, it's a little simpler to find.
Okay.
All right? This manufacturer makes a more simplified version. You just happen to luck out to go to the station with the most complex.
Gotcha.
Cool. Does this make sense in terms of the steps? Cool. All right. Let's let Michelle do one run of the apical 4, apical 5. Can we do this? Can we have you roll over onto your left hip just a little bit? Perfect. That's great. And you want to put your left arm over your head like this? That's
There
great.
we go.
Perfect. You comfortable like that?
All right, I'm getting in here, okay?
Are you guys? Go ahead and touch the 2D
Am I going to try with my left hand? I'm going to try with my left hand.
Are you right-handed or left-handed?
I'm right-handed.
Well, then
but
I would
use the
hold
front
it.
with my left.
You scan with your left
I
when you do
mean,
procedures.
Procedures, yeah.
Yeah.
So here I should
So-
probably stay with my right hand.
Yeah, I think so. I think you'll have more control. So I'd hold it like this, like a pencil.
Uh-huh.
Oh, here, I can give you this
Yeah.
back and I can show you with my
Yeah.
3D printed one. So I'd hold it like a pencil,
Yep.
indicator towards his left, and anchor the blade of your hand against
The
his skin.
indicator
Yeah, this is the black line you can feel with your
Yeah.
finger right there.
this way. Right,
Yeah,
Clark?
you got it. And the cord's not going to go anywhere. You can let go of that if you
Okay.
want to.
And I'm starting the inframemory line. Oh, look.
All right, great. You're
All
really
right.
close. You're at the heart. When I see this, what I see is that you have to fan in order to open up the chambers of the heart. So fan one way and see if it gets better or worse.
Fanning.
Fanning
this,
is-
this way with the
Yeah,
tail.
you got it.
forward.
Tail up or down.
Definitely not up.
Definitely down. Yeah.
Okay.
And if you're like, man, I'm down all the way, then try going up one rib space. Although that's pretty darn close. But go up one rib space and see if it gets better or worse. There you go. Now, look at this. This is one of the ways we get error.
Yeah.
See how the LVOT is going this
Terrible.
way? And this is going up and down this way. As a reminder, it measures speed along this line. Does that make sense?
Yeah.
Mm-hmm.
And so if you're off, your angle's off the way it was a second ago,
Mm-hmm.
then you're going to
Trying to
be
get it a little better.
inaccurate. Which direction is that error going to be? It's always going to be
Lower.
in the same direction. It's going to be lower because of geometry or trig, depending on which
Is it
whether you went
better
to
to
a public
have
high
that
school or a
aortic
private high
valve to
school.
the left of this septum when we're looking and away from it like this?
Right now you're in the RV. So
I'm
you've
in the
unintentionally
RV.
slid.
Oh,
Look
I'm-
down.
am I-
You've
yes,
slid
yes.
all the way this way. You want to slide back down now.
I see.
Slide towards the bed. Keep going. Perfect slow movements. Keep going. Keep going. Keep going. Keep going. Keep going. Yep. Keep sliding. Keep sliding. I want to get this. I want to get this under the middle of the boat. Yeah. Look how much better that got. Keep
I feel
sliding.
like I've lost everything. I have no idea. What
No, you've gained everything. No, I'm kidding. All right. So
Stop,
so
stop,
flat.
stop. Okay, fanning
There you go.
down. No, I've lost everything. Okay. I know. So.
I'll tell you, your problem might be, you're sliding a bit, and I wonder if you get at least a finger or two against the skin, that'll help you.
Okay. All right. All right.
And if you're like, man, it seems like it goes away
Yeah.
several times a minute, it's almost like he's breathing.
Stop it. Stop breathing. I'm teasing. Darn.
This is great. Don't say darn. You're
Okay,
really
I
close.
see things.
So now you've slid too far, slide back towards the sternum just a little bit. There you go. Now it's getting into the center of the screen. Now slide either cranial or caudal and see if it opens up. Not a whole rib space, just a little bit. Good. Now fan, flatten out just a little bit more. And as you fan, you might have to slide down just a little bit. You see it starting to, there it is. You see that aortic valve starting to appear right there?
Mm-hmm.
You're getting really close.
I'm trying to figure out what to
hyperechoic
do.
white line.
Yep.
Yeah, those hyperechoic white lines that are opening this way.
And I'm trying to think, do I need to go lateral?
Here, let me
Still?
just. I'm gonna put my hand on top of
Yeah.
yours just for a second. So we get right in the center of the screen.
Oh my God.
All right, and then we go. See, I'm sliding just a little bit, and then we flatten out just a little bit.
You've got it.
Yeah, and all you need to do to be able to do that quickly is several hundred of these a year. Okay.
Okay. All right.
But look down at your hand. So what I did, how did I know what to do? I was here, and when I flattened out, I couldn't see the heart at all. So then I went up one rib space. And then I'm like, wow, now I've got this great view of the heart, but it was over here. And then I said, all right, let me just slide
Yep.
until that great view of the heart is right with the septum right in the center of the screen. So can you hold it there?
Please, I can. Apparently not.
There you go. So now you guys go ahead and drag that big dot till it's just proximal to the leaflets. Great, right there. Can you slide? So you see how every heartbeat we're losing it? We need it for the whole heartbeat. So slide just really subtle stuff, a little bit more over the other direction.
Go down or up?
No, you're doing great. It's sorry, I'm talking to Michelle. Yeah. You see how like every heartbeat
yeah.
we're losing it?
Yeah.
Hey, can you take a breath in and hold it for 1 second? And then all the way out.
All the way out.
Just stay still, Michelle. Breathe out all the way. Great. Push PW.
Breathe.
push freeze.
Uh-huh.
You can breathe normally now.
Yeah. Can I relax?
Sure can.
All right.
The moment he pushes freeze, you can relax.
Nice.
And look, now we see why we were getting such a low cardiac output. So this is the second error. Because did you notice how as we were measuring, it was like every time
Yeah.
this heartbeat, it kind of went in and
Yeah.
out of phase. When he's holding his breath, you can see, oh my gosh, we were missing an entire heartbeat every time, and we were getting a heart rate that was half of his normal heart rate. That's going to give us a cardiac output. That's half of our normal cardiac output.
Oh my God, we were measuring his heartbeat.
Does that make
Taking his
sense?
pulse,
Let me check.
right? I was gonna say we could have just taken his pulse.
Right?
It's not 45.
Seems slow though.
Yeah. So, great. Yeah, but let's measure it and see what we can get here. Okay? Yeah, he might be in the 50s. Yeah. Could be just that it's changing as we have to hold it.
Right, so start with measure.
Yep. And then look down there, cardiac output in order to see your options. There you go, VO2 VTI. Oh man, this is what happened last time. I don't know why that is. Let me see this. There it is, good. Yep, left. And then do a little trace. Oh, yeah.
I'm gonna give him some extra this time.
Say again?
I'm gonna give him some extra VTI.
Yeah, yeah. This is how your pretest probability comes in. You're like, I think it's septic shock. Alright? There you go. And this is assuming the same heart rate we had at 50. Alright? And if you wanted to remeasure the heart rate, you hit that. Beginning to beginning.
So are we taking those
So
two
go
or that?
These two you can do. In a real patient, you won't have if you're actually, you should actually take every deviation. But if you're connected to the tele, you'll be able to see the QRS differences. Does that make sense? Hit the measure again. I don't know why it doesn't. Left button. That's your 53. And what happens if you go to that one?
That one?
Yeah. That's your 8. Yeah, go ahead. So this is a more typical cardiac output. Does that make sense?
Yeah.
This rotation is now over.
perfect time.
Please move to your next fill station.
If that felt like, wow, how am I supposed to remember how to do all those steps? That's okay. This is what I think of really level 3.
Oh, good.
First thing you got to do is just get your reps in and getting that 8.5 that's got to be locked before you try to do this. Because otherwise you're going to be way off. Does that make sense? Cool? Well done, all three.
Thank you so much.
Yeah.
Really good.
Yeah,
Thank you.
really.
Thanks, buddy.
Oh, anytime. Is that okay for you?
All the way to the other side.
Sorry, they got some gel on your thing. Do you mind if I just take one more look at it? That's what you can stay nice and slow.
Yeah, so that diameter can change square. For this, keep sliding.
Hello, hello.
There, that was good. Now,
Where'd they put that
now
gel?
you just tilt back a little bit.
Where are you guys coming from?
Dallas.
Dallas? Well, over there. Which station were you just at?
Oh, all the way far.
LBEF? Okay, great. All right, I'm Cameron. Very nice to meet you. Vlad, nice to meet you. Ihab, nice to meet you. Evan, nice to meet you too. This is Josiah is sacrificing his body for your education today. All right, so we're going to say thank you to him. This station's all about the cardiac output measurements. I'm going to borrow this for 1 second just to show you what we're doing. And so, and you guys a group of 3 or 4?
You guys know how to do cardiac
Okay. So just as a reminder, what we're going to be doing here is we're going to be trying to quantify the cylinder of blood exiting the heart with every stroke. That's the stroke volume. And then we're going to measure the heart rate. We take stroke volume times heart rate. We've got cardiac output. I'll offer, I'm a pulmonary critical care doc out of Paris. I'll offer that the point measurement of cardiac output that you get on this is relatively useless to me. It's got enough variability with point measurements on right heart cath that I'm like, I can't trust this in and of itself. But the trending of this is immensely useful to me. Seeing if I do an intervention and that cardiac output goes up or down by 15%, that means, and so if you can get good at this, this becomes your does my passive leg raise actually augment cardiac output? Or does starting inotropic respiration actually augment cardiac output? Or does giving a fluid get to measure what happens? Does that make sense? The first step in this that we're going to practice is we're going to get the parasternal long axis view, and then we're going to zoom in and measure the diameter of the LV, right? Because that's how we got to do our math. We got to get this diameter so we can get this area. This area times the speed at which the blood's going through it gives us our stroke volume. That times our heart rate gives us our heart rate. Questions about the conceptual model that we're going to be doing? I feel like it's nice to have that in your head as you're doing the motions rather than just being like, I know to click here. Right? Evan, you're closest to the patient. Go ahead and grab a probe. Vlad, you're closest to the machine. Why don't you come over and push buttons while Evan does. There you go. As always, it's important to warn your patient that there's going to be cold gel, otherwise evil spirits get them. Great, you push the 2D button, that gets us into 2D mode. Let's start with our parasternal long axis view. Two things, just make sure you've got at least one finger good anchored against the patient's skin because the gel is such a good lubricant. Indicator towards the patient's right shoulder, perfect. Let's pause right here. Hold as still as you can. You see how during the respiratory cardiac cycle you're losing your vision? So just slide a little bit cautiously. There you go, pops right back into view. A little bit more, a little bit more. A slight bit more. What I'm doing there is I'm finding the space where the lung's not getting in your way. Does that make sense? Let's go a little bit more cautiously. See how these A lines are coming into view? That means we got a lung in the way. Once you've got a place where you feel like, man, I'm getting it most of the time, then we're going to ask Vlad to push the zoom button. Zoom button. And actually here, Evan, can you do this for me? Can you rock a little bit? And that's going to bring this closer to the center of your screen. So go ahead and use a rocking motion.
That's rocking, right?
No, that's fanning.
Oh, shoot. That's rocking.
Yeah, rocking is along the axis of the transducer. That's great. Go ahead and zoom in a little bit more, Vlad. A little bit more. And go ahead and slide just a bit. Here, I know what's going on. Can you see how you're pointing up towards his chin? Rotate just slightly counterclockwise. There we go. Now we're starting to see those aortic valve leaflets. Does that make sense? Yeah, right there. Yeah. So go ahead and push the freeze button. All right, and you can relax your hand. And now you might say, man, this place where I froze it, you actually did a great job. This place where I froze it isn't the one I was looking for. And it's important to remember you can go back in time on these machines and find. So what we're looking for, we want to measure this diameter. And the place we're trying to measure the diameter is just proximal to the hinge points of the aortic valve leaflets. Does everybody see this? Holler if you don't, because I'm from Philly and I'll keep talking otherwise, all right? Yeah. You got it. So those hinge points of the leaflets, and when during the cardiac cycle do you want to measure it? Mid-systole. He is in asystole according to his teleleads, all right? So that's not going to help us out. So instead we're going to use the fact that when the valve's closed, it's diastole, when it's open, it's systole, and you're going to roll that ball till you get to the point of closed. You're going to roll it to the next point of closed. Keep going, and then you're going to go halfway between the two. Does that make sense? You go diastole, diastole, halfway. Beautiful. And now we're going to measure that diameter. So we click the measure button, and then if you look down here.
What time? Mid-systole, you said?
Mid-systole, that's right.
So wouldn't the leaflets be open?
Yeah. Sorry. See how we got, oh, sorry, we went to, how do we turn that? Oh, I messed you up. Go wait.
Sorry about that.
That's not your fault, it's my fault. Go ahead and get yourself back to that place, Evan, and we'll zoom in.
Sorry.
You apologize. I'm the one who pushed the wrong button on the machine. Great, perfect. Free, zoom in on that.
That's it.
You can actually get ourselves over there.
Before I lose it?
Yeah, freeze. Great.
There you go.
All right, so now we've got closed, open.
There you go. Midway through.
Yeah, right there. All right, so let's measure it now. All right, so hit the measure button. If you look over here, before you go down there, you'll notice that it's got a bunch of different options to measure. All the machines will do this. So you could just do that measurement, or you can tell it, I am measuring my LVOT diameter, conveniently with a check mark next to it. All right? And when you do that, it internalizes that number for calculations, instead of you having to do the arithmetic outside of the machine. So go ahead and measure from here.
Oh, you did say it's your hinge point.
Yeah, the hinge points, that's right. From there to there. And just roll, left mouse click. Yep, there you go. And scroll down. And then to save it on this machine, do middle mouse click.
I click this guy.
Nah, just this guy. Great. Look, LVOT diameter, 1.8. Don't worry about this stuff. LVOT area 2.54. I'm going to offer, I'm going to remeasure it for you just to show you how variability in the way that you measure this becomes really important. So just by slightly changing where I put the dots, right? My diameter went from 1.8 to 2.0. That's not much, right? That's a millimeter on either side.
Wrong.
But say what?
Wrong.
Yeah, exactly. That was a 30% change in his cardiac output because this is an exponential error. So how do I mitigate that when I'm actually doing this? I don't repeat this measurement. I don't actually use this measurement. I assume everybody's got an aortic valve diameter of 2. Because I don't care about the point estimate of cardiac output. I care about which direction it's going. And I'm in a MICU. I don't deal with aortic ascending aneurysms. My patients' aortic valves are not changing in size from 1 hour to the next. So I don't need to redo that measurement. So I don't need to put this error into it. Does that make sense to everybody? Cool. So I'm not going to have anybody else struggle their way through that unless we run out of time and you guys want to practice. We're just going to save this LVOT diameter. All right? And now comes the fun part.
So you're basically seeing trending in VTIs.
I'm trending VTI times heart rate because the heart rate's very important. All right? All right, so now we need to do what we need to do.
Why would
Start
you go
working
to
on getting
the
an apical 4 while he's asking. Yeah.
Why would you go to the LVOT? Why can't you get it from the carotid?
Great question. It turns out that the carotid diameter does change dramatically from minute to minute, hour to hour. But that study's been done. One person said you should totally just be doing this from the carotid or the femoral artery. And then they were like, look, it works great. And then somebody tried to repeat it and they're like, no, it doesn't. So that there is a body of literature about that with that argument. All right, let's pause for a second. You're right on this nipple. I like to think of my apical 4 being inframammary. And just in case we aren't scanning any standardized patients with breast tissue, but if I am, the way that I do that is... sorry. The way that I scan a patient with breast tissue is take the back. I'm assuming a patient's not able to lift their own breast. If they are, I say, do you mind lifting your own breast? Placing the probe underneath it. Take the back of my left hand, lift breast tissue out of the way, take the transducer and literally put it right at that inframammary crease. Somewhere lateral to the nipple, and then I can slide medial or lateral, and it's almost always 1 rib space up or 1 rib space down. And that's how I find my apical 4. And what body position can we do to help us a little bit with the apical 4? Yeah. Do you mind rolling over just on your left hip a little bit? By the end of this hour, you're gonna be able to teach this course.
You know, right?
And I'll offer, if you're like, man, this is a really awkward position. First, you can drop this. You can almost imagine being on this side of the bed and how you'd have a little better luck doing it from there.
Yeah.
All right.
It's too hot.
Yeah, it's okay. So we're gonna give him a little less depth. So you see that depth button right there? You're gonna knob that. Yeah, there you go, perfect. And you're gonna flatten out just a little bit. And this isn't a great window. You got a rib right here that's kind of blocking your view, but it's good enough. So flatten out. Good. Pause right there. Beautiful apical 4. So now here's the thing about the apical 4. It's close to our apical 5, and to get from apical 4 to apical 5, it's a subtle fan anteriorly on the chest. So
What's the 5 again?
the 5th chamber is that aortic valve that's trying to sneak into view. Yes, it's right there. Do you see it right there? So now, Vlad, you're going to take this, and you're going to put that dot right at the place where you measured it. So there's the leaflets. So just go up a little higher. Yeah, a little higher so you get the leaflets.
To be perpendicular, so I wonder if
Oh, he moved on you. Right there. Yeah, right there. For the sake of time, go ahead and hit pulse wave. Hold it still. Hit freeze. Amazing. You can relax your hand. All right. This baseline is adjustable. You can move that up and down. The scale, how big those things are adjustable. You can see the things right here, baseline and scale. What you want to be able to see is the entirety of it above this bottom line, because if it goes below the bottom line, it comes back out the top. Does that make sense? Perfect. All right. If somebody has massive aortic regurgitation, you'll see after every beat a massive upward deflection. I use that a ton to identify subtle AR that was missed. Right? So now we're going to try to see how much blood comes out there. So go ahead and hit the measure button, the cardiac output button, and that gives you, what the cardiac output button does is it deletes all the other stuff that you can measure except the 3 things you need to measure. So go ahead and hit LVOT VTI. Great. And now comes the fun part. You're going to use this and you have to trace from here to there. You're going from the orange line, the entirety of that cardiac output. Second, left click, and then draw with your hip. Back up. Great, great, great. Keep going, keep going, keep going. Great. And then hit the middle button. This guy right here. Great. Your LVOT VTI was 14, right? 13.8. As a reminder, if somebody has a heart rate of 60 to 80, your LVOT VTI should be somewhere in the 15 to 18. Right? You're not far off. The nice thing about this is you know which direction your error is going to be. So just to say that out loud, all the things we've done so far, the angle you're at, where you put this, all of this add up to different errors. Aside from the measurement of the diameter, anytime you're off axis, anytime you put your dot in the wrong spot, anytime you cut this too shallow, all are pointing you towards measuring a lower than actual VTI, a lower than actual cardiac output. And I use that. That means that if I come out with a high number, I can feel more confident that I'm in a high cardiac output state. If I come out with a low number, I gotta be like, did I do this right? Does that make sense? Cool. And the last part of this is measuring the heart rate, so go ahead and hit the heart rate button, Vlad. Great. And what that does is it gives you a line. You drag that line, you drag it to your next heartbeat, which he's not actually going 46, we just kind of missed it, right? And you get your cardiac output. Does that make sense to everybody? Cool. Questions about that?
So, is there an angle you would accept to match the Doppler with the LVOT?
Yes. In the American Society of Echocardiography, they say if your angle is off by more than 20 degrees, then you're probably generating bad information. Right? And that's why you do a little bit of fiddling around, the fanning, the rocking that I was talking about. Lets you see it. Cool? All right. Evan, you want to push buttons? Sure. Vlad, actually, can we do this? Vlad, you scan, and then we'll go from there. Oh, they're locked. All right.
Still got the plastic on this.
Vlad, you look like an expert already. Hip against the bed.
right where the blood.
There you go. Starting to see heart. Now, when I look at this, what I see is that the apex of my heart is under the dot. Does that make sense? So that means I need to slide just a little bit laterally, a little bit closer to the bed for now, and then go a little bit inferiorly to get that. I might be wrong because I'm not looking at your hand. Sorry.
I think.
Here, look down again here for a second. So you're shooting like this. Let's pretend this is a flashlight. Where's his heart? His heart's up here.
Yeah.
There you go, and you fanned, and there it is. Keep fanning just a little bit more. When I say fanning, what I mean is this. Flatten out against the skin just a little bit more. A little bit more, and you want to see that aortic valve open up. Nice view of his tricuspid. You're really focused on his RV right there, the people's ventricle. Is what likes to And so, one of the things that my favorite echosonographer likes to say is if you're dissatisfied with your current window, go window shopping. Just check one rib space up and one rib space down. Wow, look at that. All right, now flatten out a little.
There is a big difference.
Did you go down there?
So if you measure too small, you're gonna get swallowed.
And this is going to be,
So that is like
this is something that comes with time, but if you look at my hand, look at me for a second.
Yeah.
So you've got this nice, this is his rib.
Yeah.
You got this nice window right here, and you
Yeah.
fan, then you point at this window. You're pointing right at the rib.
Got it.
So what do I actually have to do? I have to slide and fan. Does that make sense? Yeah, fan just a little bit more. You're so close. Yes! Alright. Even, Evan, sorry.
It's okay.
Use the mouse ball to roll until that big orange dot is right proximate to the aortic valve. Up, left a little more. Keep going left. So that's a mitral valve that you're in front of right now.
Oh, shit. I'm lost then.
So it's going to appear. There it is. See how it's coming in and out of you right there? So your dot's trying to be right there.
Okay. Right there?
Yeah, now, can you flatten out just a little bit more?
vacuum flat against the skin. Yeah. Go and push. You got it in a good spot right there.
Yeah.
Just try to get off the valve leaflets. You can do it in the black as blood.
Right there?
Yeah, flatten out a little more. Blood. Yeah, there you go. Push the PW button. Push it.
Where is it? PW. Right there.
Push freeze.
All right, you can relax your hand. All right, it's not always that hard to get.
Sorry.
It's not you. It's not you. It's your first time doing this, I'm assuming. All right. So now same thing. Evan, do you want to do it this time? Because I did it.
Yeah.
All right. So now you push the measure button. And now this is a great example of when we get ourselves into trouble, right? You might be looking at this and being like, what part of this do I measure?
Yeah, if I had to guess, it'd be...
So you always start from the orange line,
Okay.
right? Because blood's going from 0,
Sure.
right?
Start right there.
Yeah. And then you see how it's got this faint shadow?
Yeah.
And then the bright white shadow? To me, that says we fell off axis.
Okay.
But the textbooks would say measure the chin, not the beard,
Okay.
is kind of how it's described.
Right.
So you click the left button once, then you start drawing. Ooh, sorry. We messed up. We forgot to tell it what we were measuring.
Right.
So we go to measure. LVOT BTI. Click once. And then drag.
Oh, am I too far right though?
Yeah, whatever. Yeah, I mean, short answer, yes.
Yeah.
But like, what percentage of it are you missing? 5%? Right?
And then I just cut down.
You cut back up to, when you think you're there, you cut back up, that's right? Yeah.
Cut right there.
And then push the middle button. Great, and it says that you measured an LTBTI of 11, which makes sense. That's way less than we got before, because we were quite a bit off axis by the time we finally got down. Does that make sense? But that's the hand technique of get the view, get at least a few heartbeats, measure at least 2, ideally 3, and then you average it. Does that sound good? Where do you get into trouble with this? AFib. Then you need to get 5 heartbeats. If you got big respiratory variability, then you got to get enough heartbeats per respiratory cycle. So if somebody's really bradycardic, you can get some really wild swings in what you're measuring in cardiac outputs.
If the patient's holding their breath, and you do the same measurement, what kind of variable? Let's assume you do a perfect reproducing.
Yeah.
But one of them they're holding their breath.
Yeah.
Is this how much does it affect them?
So holding the breath helps because then I don't have respiratory variability baked in.
Right, but does hemodynamics that you measure change?
Depends
Because
on the
of the breath.
situation. So if I got somebody who's like crazy volume volume down and they hold their breath, all of a sudden I've decreased their inspiratory preload. Right? If I got somebody with bad pulmonary hypertension and do this, you're going to see what that increased breath hold does to you. But in general, the way I think about it is this: if you get good at this, and that's doing it 20 or 25 times, it's not an insane number, at least according to the literature. Then you're talking about a variability. Same provider doing a variability, a measurement to measurement variability of about 5%. That's not enough. But when we draw our threshold at 15% changes, I'm like, all right, that's about a standard deviation outside what our normal repeat observed variability is. And then if we're like, hey, I'm not trying to get the person's cardiac output is changing by 50%. I'm trying to get the person's cardiac output is changing by 30%. If I take this guy and put him on inhaled flow nitric oxide, and I'm like, am I bypassing his PE? You're going to see that as a yes or no. Does that make sense? What I do a lot of is I'm categorizing someone as being in a high cardiac output state or a low cardiac output state. And with the other bit of information I get from my lung ultrasound, my basic cardiac ultrasound, and all the labs and hemodynamic measurements are taken otherwise, that binary helps me. It helps me go, hey, is this somebody who I need to increase their cardiac output in order to improve their tissue perfusion? Or is this somebody where like they're already achieving high cardiac output? What I need is to figure out basoplegia. Does that kind of conceptually make sense?
Have you had success titrating ionotropes with us?
Definitely. We use this all the time when we're weaning somebody off ECMO, when we're trying to just wean somebody off of epi, and when we're trying to wean somebody off of inhaled vasodilators. Like that's when I use this most. That way I don't have to wait for their lactate or their urine output to drop, right? I do this, turn off the inhaled nitric. I checked 5 minutes later, and I got my answer. You know? Cool. Yeah, do you want to scan?
I'll try.
All right, so we get the 2D button to get you back into scanning mode. Okay. Again, the only thing is, don't start doing this. Don't start making clinical decisions on cardiac output measurements until you're really good at apical 4, apical 5, right? If you're struggling to get your views, then you're going to get bad information, and that's worse than no information, right? And you're going to frustrate yourself because you're going to be sitting here for 10 minutes and you're going to be like, forget it, I'm just using the pulse pressure. Right? Nice. Beautiful apical 4.
Bring an echo.
Yeah. And I think what I'm seeing you try to do, if I'm having to guess, is you're trying to fan like this. And as you do it, just slide a little bit inferior. Yeah. See how that brightens it up? There you got somebody who's ready to jump on it.
Let me try and do it. The window shopping. Let me go one down.
Okay.
And fan further.
Yeah. Great. You're so close. And this is where you can also say
And
to
my
him, hey,
hand is in between, so let me change.
you can say, hey,
this.
can you take a breath in and see whether that puts things, where that puts his heart. Do what you just did there, flatten out even more. You can see the entirety of the aortic valve right there.
Yeah.
Right? There you go. So now get it so you're seeing, so flatten out just a little bit. Flatten.
Yeah.
Slide, yep. And you're like, man, this is tricky. Yeah, it's totally tricky. Good job, Rock. Go ahead and get in the right spot for it. Flatten out just a little more.
It's as flat as it'll go.
Then you have to go up one rib space, unfortunately. Oh, yeah. I'm just going to go look at your hand. So I'm going to take your hand. I'm just going to nudge you slightly. Keep your hand on it.
Okay.
There you go. That's it right there. Do you see it?
Yeah.
So go ahead and...
Where is PEW? Okay.
Oops. Unfreeze it. So you don't freeze it yet. You have to push PW first. Right next to the orange. Yep. Push freeze. And then you can scroll back in time until you find a good one.
Oh, so if you freeze it, it doesn't. You can't go back in time.
You can.
Okay.
But
So
You can't add PW.
we can't add PW.
measure. No.
You can't add PW to a frozen image. All right. So go ahead and tell it what you're gonna measure. So you're gonna go to cardiac output. You're gonna hit measure. You're gonna go to LVOT VTI. Great. Trace that line. Perfect. Left button. Yeah. That one. And you'll notice if you get really overeager and you accidentally cut things off, if you go backwards, it erases it.
Okay.
Nicely done. That's a great angle. We've mitigated our angular error that we had before. We found his actual
So
cardiac.
let me, and I want to do the heart rate thing that you just did. So.
So you push the middle button to save your VTI. Yep.
Okay.
And then you hit heart rate
Heart rate.
and go from beginning to beginning.
Can I do peak to peak or no?
You can do peak to peak if you want. Yeah. I mean, as long as you go to the same point on each second. Right?
How do you know his angle is good?
How do I know? Because his measurement was better.
Yeah. Got it.
And then left
Because
button
I do
again?
not believe our standardized patients are cardiogenic shock.
Sure.
What
Yep.
happened?
It's not the left, unfortunately. It's the middle button.
Okay, so let's do that again.
Yeah, good. So hit the left button, and then scroll all the way back. Oh, it's not letting you. Here, push measure again.
Measure
Heart rate.
heart rate.
There you go. Now you can do peak to peak. And so it's left button the first time, middle button the second time. If you're
Oh,
like,
okay.
why did they do this? I don't know. There you go.
Okay.
Really slow heart rate, normal VTI, relatively low cardiac output. That's how it should work out. And again, this is with us measuring his LVOT diameter. That's exactly 2 centimeters.
Okay.
If his is 2.2, all of a sudden we're in an entirely different range. for cardiac output, but our VTI hasn't changed. All right. While he helps doing another attempt at getting that without my head on his. There's questions about how you would do this, how you would apply it.
Nope, not measure first.
Before you do this, to make sure you have you're Dopplering the correct flow.
CO, where it says cardiac output.
Yeah.
There you go. That makes things more simple, right? Takes away all the other options. Before you do this,
So before you do this, to make sure you're in the right spot, can you technically do color
sure can.
to see the jet that you're actually measuring?
Sure can. I'll offer that because the color doesn't necessarily tell you the magnitude of the flow, just the directionality of it.
Right.
It doesn't. It's less important for this than it is for when you're doing your RV station and you're doing PA SPS. So look, this second time you measured it, your error was about 7%. That's not bad for two separate measurements, right? You went from 18 to 20. That's not bad. All right? Yeah. Other questions about this? Great. You have time because we set it up so that there's time for before here before. Go ahead and do something like intentionally wrong. See what you get if you look at it really off axis and see what that does to your measurement. Got it. Do the mistakes you're going to see people make. Do you guys work in academic centers with trainees or? Yeah. So like, I have this thing where like my fellows come up and they're like, "Hey, I did a cardiac output and this is the number," and I'm like, "Well, that doesn't help me because I didn't see like what the picture looked like." It helps me if it's high. Doesn't help me if it's small. So what you're doing right now accidentally is you went to the sector button. You're changing. Yeah, there you go.
So let's say if I put it there.
Perfect. That's it.
Right. So you do.
There's the PW button right next to the orange triangle.
But the angle
Where's the
is.
Yeah, he's doing it on purpose.
Oh, okay.
Yeah.
Sorry.
So here, hit this guy.
Yeah. Okay.
Let me just get it closer.
Let's freeze it. And why is it? What's these spikes? Does he have aortic regurgitation? No. You're catching because of where you are. You're catching the septum. You're catching the valve. You're catching his mitral inflow, right?
So you're not getting a clean representation of the.
Yeah. And that's where it's helpful to me. Is like if I can see that picture, I can be like, does that look like it's supposed to look? And if not, which direction is that going to influence my error? I agree. You see, like right now, you're all up in the aortic valve. So don't hit pulse width there. So look at that. What that is. See how fuzzy and the valve leaflet gives you that vertical line all the way down? That's how you know, oh, I'm too far in the valve.
I feel the same place.
Make sense?
Honestly, like the heart center, they're the most difficult.
So okay, since we're in this view, why wouldn't a measurement here be accurate?
So the blood flow, right? The blood flow, the measurement of speed is speed in this direction, top to
Oh,
bottom.
that's right. Okay, that's right.
And in this case, the blood's going like this.
Got it. Okay. So the direction. That's why if you're off axis, the whole thing is messed up.
That's right. The whole thing's messed up in a predictable way.
Gotcha. So you have to set up yourself in the proper flow.
You got it. And like I said, they accept. Now, these machines are fancy. You can actually have them do that angular correction for them. But the standard of practice for echosonographers is not to do that.
Got it.
But it's instead to say, let me get a view where I'm less than 20 degrees off with my angle of flow. And now he's thin. So sometimes you're not going to be able to get as crisp of a view as you have here. But it turns out that that's okay, because even when you can't get a crisp visualization of it, the speed of blood flow can sometimes be picked up by the machine. It's going to really affect your accuracy of your valve diameter, but again, I don't really use that very much. Great. See how small these are?
The amplitude is there.
That's because you haven't. That's because you're not in the.
You're not in the pro. Yeah, got it. Makes sense.
Cool. You want to give another go? You want to try something else? Yeah, sure. So the advantage of doing my right hip's on the bed and I'm leaning over a patient is my left hand's on the machine. Now, in my IQ, it's often like CRTs over here and vents over here, and so I just put the machines wherever there's space. Right? I don't set up.
Oh, you know what? I'm backwards.
You
though, right?
are. I was going to see if
Yeah, yeah. It looked so good, though.
Nice. And the trick is, yes, you see how the septum is pointing towards the dot? It means I need to slide towards it. So slide towards it. Yeah, you see how it's starting to like... Yeah, that was really pretty.
Right there? Right?
Yeah, just yeah, perfect. There's an in the LVOT.
Towards the valve?
You're going to get right next to those leaflets. Yeah, there you go.
Yeah.
And push PW right next to the orange one. Right, freeze, go back, you got it.
Alright, and then... So that's okay, and then I hit to measure, and it's measuring.
Output? COLVOT.
Yeah, the one above that. You can do that. You went.
Huh?
So just as a note, when you hit COLVOT, all it does is remove all the options that are irrelevant to it. It doesn't
Okay.
So the one you clicked is fine, but now it makes it a little cleaner.
Okay.
Does that make sense?
Cool.
And that's just all that is a package. It's like, oh, I do this frequently enough that I want to have a cleaner interface for it. Left click and then
Hit LVOT VTI after.
you have to hit measure again.
So
Measure.
this one over there. See that one?
And then
Go ahead.
and then click. You have to click left
Oh yeah,
click.
click. Measure. Measure? Yeah. Oh, but I didn't hit and then I have to hit
Yeah, sorry.
this.
So
Hit
just
measure again.
Oh, right.
Yeah.
So, do you want this one active or you want
No,
it
it's okay.
erased?
Yeah, here, hit measure again and it'll actually help us out.
Oh, really?
Okay, measure.
Yeah, and then hit LVOT VTI. Now you can go. Now left click and start.
Oh, well. And then measure again. Right.
Cool. And you got crazy low. All right. We know this is almost twice that, and it's gonna be because the angle of your septum means that you're off by probably about 45 degrees instead of 20.
Okay.
And because look at when we finally got the pulse wave. Look at where our pulse wave is. You were like deep in it at the very beginning, but look when you finally got it, the valve's all the way down here, and you're all the way up there.
Yeah, okay.
And so you're not catching where the blood flow actually collects into the valve. If you think about it, when it's going through that big area, blood flow is slow. When it goes through the smaller area where you measured your diameter, blood flow is fast. So that's why that's why I was saying go deeper in there.
Sure. Okay.
Does that make sense?
Yeah. All right.
Cool. Other questions about this?
Maybe a few more views while we're here.
Yeah. Do you want? Now this is your chance to practice your
Yeah, sure. You mind just laying flat for us? You mind just laying flat for us? You out? He's asleep. You mind just laying down flat?
Dude, do you mind rolling on your back? Sorry about that.
I didn't know.
It's all good.
It's a reminder of how this is not a painful procedure for anyone involved.
Oh, thank you.
I'd like to call out the expert technique of putting the gel capside down. Catch the bottle in the fridge.
Alright, just gonna go lower down, okay,
So pause right here. It's almost no pressure. Look, when you lighten up pressure even more, lighten up, your image hasn't changed at all, right? You don't have to push hard in order to get this view. And then if you're like, man, I can't see the heart here, the problem isn't that you're not pushing hard enough. It's that where you are doesn't give you the sonographic window that you want. So what I'm going to do, keep your hand on it.
Okay.
So I'm just going to slide down and then flatten out. And what I'm doing as I do this is I'm trying to find a spot where I can use the liver as my acoustic window instead of trying to shoot through valve. The place that people get into trouble is they start right here and then they got a patient with a extended gastric bubble and the stomach's blocking their view entirely. So by going away from the heart counterintuitively, you can sometimes get a better view.
So close.
And now the other trick, if you can't get it, is you say to your patient or the ventilator, take a deep breath in and hold it.
Take it. Yeah.
And there you go. Now flatten out just a little bit more. Too much. There you go. Perfect. You'll notice that you have a subcostal 5-chamber view right here. You can do LVOT BTI. One of our instructors here loves that. He's like, all I need is a subcostal window. I don't know. My experience with the subcostal window is it is more vulnerable to angular error because you're farther away. Doesn't mean he's wrong, just that it's, you gotta get going. Switch to a pencil grip when you're doing the card.
Oh yeah, thanks.
There you go. Christine, and to change your depth, it's the knob and you twist it. Yep. Whichever way you think it is, it's always the other way.
It's okay.
Did you say 5 minutes? Yeah. Thank you very much. You're very welcome.
Oh, I hit something. Did I hit something? No? I thought I hit a button.
That's certainly possible. But your view looks fine. Nice parasternal short.
Yeah. And higher up, do you see right ventricular outflow? It should be somewhere up there, right?
Yeah, that's where your RVOT is. Don't get me wrong.
Yeah, I can't get it there.
Yeah, it's, I'll be honest, it's pretty hard in critically ill patients to find the RVOT.
Yeah, okay. And in healthy ones too, apparently, for me. Okay, very good.
But again, blood in, blood out. If you wanted to do, you could do your RVOT VTI the same way we just do our LVOT VTI. You just
Sure.
have to, you just have to acknowledge that the size of the valve is so different.
Yeah.
That you can't use the same scale. Okay. But it changes in either direction. It changes in either direction.
Very good.
Awesome. I am seeing if there's anything else out there.
This is the end of the rotation.
Perfect.
Please move to your next skill station.
Nice to meet both of you. Yeah, you're welcome.
Thank you very much.
Yeah, you're welcome. You're doing great. Sorry
Thank
to wake
you.
up. You right?
Straight up to the next